Okay, I have sent this lecture. Can you see? Yes, Assalamu alaikum. Can you see? Should I proceed? Hello? Hello?
We can say, Doctor, can you start?
Okay. So, Bismillahirrahmanirrahim. Today's topic is about airway management, how we do the airway management in case where there is airway obstruction. So, now we have basic airway management. There are basic airway maneuvers. For example, if a patient is coming to you with airway obstruction, possibility is that the tongue is falling to the posterior pharyngeal wall. Okay, so when the tongue falls to the posterior pharyngeal wall in a patient where there is decreased level of consciousness, what are the options that you can do? How you can do the basic airway maneuver to open that airway? So we will be focusing on the airway obstruction in case where there is decreased level of consciousness, or it could be any reason, and mainly because of tongue is falling to the posterior pharyngeal wall, how we can do or how we can tackle that situation. Now, the first, as I said, it is head tilt and chin lift. This is the first basic maneuver, head tilt and chin lift. It can be asked in your exam, what are the basic airway maneuvers? So head tilt, chin lift is the first, then jaw thrust, and then third is the modified jaw thrust. So these are the basic, what you say maneuvers that maybe if you have done the BLS also, you can hear these type of maneuvers there. Now, this is the maneuver that we do that is known as the head tilt chin lift. Here, what I'm trying to do, I'm trying to keep my one hand at the forehead and other hand, other two fingers, index and the middle finger at the mentum of the patient. Okay, so I'm trying to lift this chin up and at the same time doing the head tilt. Now, why I'm doing this head tilt? It's because to align the airway. Okay, so there are axes of airway. For example, this is oral axis, this is pharyngeal, and this is laryngeal axis. Now with this head tilt, what I am trying to do, I am trying to align this oral axis towards the pharyngeal and laryngeal axis. So if you have been asked why we have to do the head tilt, it is to align the airway. And there is one more important, why we do this is because we try to stretch the pharyngeal wall in order to open the airway. Now, why we are doing this chin lift? We are trying to lift the jaw up. When we do the lifting of jaw, there is, tongue that is attached to the by the genoglossus muscle. It is attached there. So you will try to lift the tongue away from the posterior pharyngeal wall by turning or lifting this chin up. So head tilt chin lift, it is the basic airway maneuver that you can do to open the airway. So the question, you can get a picture of this. Okay, you can be asked what is this maneuver, why we have to do the head tilt, why we have to do the chin lift, what are the reasons for doing the chin lift. You can get questions like this. So try to keep this picture in your mind. Now, the second, if there is a patient with road traffic accident or any other case, fall patient, where we suspect that there is possibility of cervical spine injury, in that situation you cannot do this type of maneuver. Why? Because if there was transaction in the spine, cervical spine, it can be a partial, can convert into the full transition. So we have to be very careful in a case where we suspect cervical spine injury. Now, if the patient with cervical spine injury is coming to you, now the patient is having airway obstruction as a result of tongue falling to the posterior pharyngeal wall, what could you do? What are the possibility, what are the options for you to open the airway? This is the maneuver that we can do. This is known as the jaw thrust. Okay, so just this maneuver, just try to remember in case where there is suspected cervical spine injury. Now, what we try to do, we try to keep our fingers at the angle of the mandible and try to push it forward. We try to push it. So we try to push it forward so that the tongue will be lifted away from the posterior pharyngeal wall and airway will be open. Okay. So this is how we can do. Can you close the mic? I can hear the echo from anybody. Have kept this, kept your, you have kept your mic open, someone. So you have this option. This is known as jaw thrust. So in exam, you can be asked, what is this picture? This is the jaw thrust. Why we have to do, in which situation we can do this? In a patient where there is cervical spine injury, you can do this maneuver in order to open the airway. Now there is third one that I discussed, that is known as the modified jaw thrust. Now in modified jaw thrust, what we try to do at the same time, here I was not using my thumb, but the mouth was open. Sometimes what happens, the mouth is closed. In order to open that mouth, we can use our thumb. At the same time, we are doing the jaw thrust, but yes, we are trying to open the mouth in order to get this airflow inside. So this is known as the modified jaw thrust, where simultaneously you are doing the jaw, lifting it up forward, and at the same time you are trying to, what you say, you are trying to open the mouth at the same time. So this is known as the modified jaw thrust. One second, I will use this mouse. Okay. Where is the mouse? Is there any option? Okay, so you can use this, you can do this jaw thrust maneuver at that time. Now, how if a patient is not breathing at all? Now, if we have a situation where the patient is not breathing at all, what we can do in that situation? You have to hold this, what is known as this, bag mask valve or bag valve mask. So you can hold to do the, ventilation, positive pressure. You have to give the positive pressure breaths with this bag valve mask. So we have this ambu. This is also known as ambu. You can do single hand technique or you can do the two hand technique that I am going to discuss. So if a patient is not breathing at all, you try your best to open the airway, but still you are not getting, your respiratory efforts are not good. What you can do, you can hold this manual resuscitator and you can use this technique of C and E. What I am trying to do, I am keeping my index finger and thumb at the body of the mask and rest of the fingers at the mandible, mandibular bone. So I'm trying to lift the chin up and at the same time keeping the pressure on the mask in order to make an adequate seal. So simply, if a patient is not breathing, you can ventilate with this manual ventilator by C and E technique, and this is the single hand technique. Now the other, if you are not able to ventilate with this technique, you can use both the hands and other person is going to ventilate at the same time. So you are holding the mask with C and E on the both sides and the other guy is going to ventilate at the same time. So this is known as the two hand technique of mask ventilation. Now if we fail when we are doing this mask ventilation, but still we are not getting visible chest rise, patient is not breathe, you are not able to ventilate that patient, it could be reason could be you are not able to lift the tongue away from the posterior pharyngeal wall. So what you can do, you can use airway adjuncts. These are, first is this oropharyngeal airway. Now, there are different sizes of oropharyngeal airway. These are known as Goodell's airway also. So you can use this. Maybe you might have seen these oropharyngeal airway. So what the function of this oropharyngeal airway is, it tries to lift the tongue away from the posterior pharyngeal wall. What we were doing with jaw thrust, what we were doing with head tilt and chin lift, it's trying to do the same job. It's trying to lift the tongue away from the posterior pharyngeal wall. So you can do this, you can put this oropharyngeal airway. Now, indications for putting this, there should be, air for airway maintenance in unconscious patients. Protects an endotracheal tube, from being bitten. It facilitates airway suctioning. Now, these are the other indications, like, preventing the endotracheal tube to be bitten by the patient or to facilitate airway suctioning. Now, question from this topic or this oropharyngeal airway, you might be given picture of this and you might be asked, what is this? So you just remember this is oropharyngeal airway. Now, the second important, what are the contraindication? You might be given question, following are the contraindication except, okay? So in a patient who is conscious or in a semi-conscious state, you should not put this oropharyngeal airway. Why? Because it can lead to gag reflex and patient can have problems like aspiration, bronchospasm, laryngospasm. So you have to avoid putting this oropharyngeal airway in a patient where there is semi-conscious state or conscious state. Okay. Now, the other question that can be asked is, what are the contraindications? So in a patient conscious, intact gag reflex or oral pathology, you should not put it. And how to estimate the size of oropharyngeal airway? You can see this picture. I'm keeping this oropharyngeal airway here. I'm measuring the size from the angle of the mouth to the angle of the mandible. Okay, so if you have been asked what is the correct, how you can measure the size of this oropharyngeal airway from angle of the mouth to the angle of the mandible, you can measure the size of oropharyngeal airway. Now, the second airway adjunct is this nasopharyngeal airway. Now, if you have a situation where the patient is semi-conscious, patient is not able to breathe properly, patient is having airway obstruction, this situation, we can have the situation, especially in obese patients who are obese. You give small sedation, they have this tendency that their airway collapses or their tongue falls to the posterior pharyngeal wall. But at the same time, you cannot put oropharyngeal airway in such patients. Why? Because they are semi-conscious. Maybe they are conscious, but still they have airway obstruction. So what to do in that situation? You cannot sedate more, or you don't have that option that you can put the patient on ventilator. So you just want to have some device that is going to rescue you in that particular situation. So this is the nasopharyngeal airway, what we can use in a situation where patient is semi-conscious but still there is airway obstruction. You can use this nasopharyngeal airway. Now, how to measure the size of this nasopharyngeal airway? It is from the tip of the nose. Okay, so you can measure from the tip of the nose to the tragus of the ear. From tip to the tragus of the ear, you can estimate the what is the size or the length of this nasopharyngeal airway that I can use in this particular patient. Now, there is one more thing about the internal diameter. Your internal diameter, that is the inner side diameter. What should be the, how you can measure? You can measure by the little finger. By little finger of the patient, you just see what is the size or internal diameter. You can estimate the size of this nasopharyngeal airway. Now, what are the contraindications that can be asked in your exam? If a patient is having nasal pathology, if the patient is having problem in the nose, you should try to avoid. If there is basal skull fracture, you should try to avoid. If there is bleeding tendency, you should try to avoid. And if the patient is on anticoagulants, this is one of the contraindication that you should not put this nasopharyngeal airway. So the question from this topic, it could be, one, what is this picture nasopharyngeal airway, how you can estimate the size from tip of the nose to the tragus of the air, what are the contraindications, what is the major contraindication, that is the basilar skull fracture, that is the major contraindication for putting this nasopharyngeal airway. Now, in which situation it can be used in, it can be used in a patient which is who are semi-conscious patient or conscious patient. You can use this nasopharyngeal airway for rescue of ventilation. Now, the other is this, what is known as the laryngeal mask airway. So, this is one of the important instruments that we use for airway management. Okay, so you can, the beauty about this laryngeal mask airway is that you don't need any high skills to put this laryngeal mask airway. If you are posted in ER or in any emergency situation, you can learn within 2 or 3 days, you can learn how to put this laryngeal mask airway. And more important, how why it is important, because if a patient is not breathing well or you are not able to ventilate patient is unconscious, you can easily put it and you can ventilate the patient. But the only thing is that it is not a definitive airway, like it is not going to prevent patient from aspiration, but yes, it is going to rescue the patient from respiratory arrest. Or if you are not expert in putting the endotracheal tube, you can use this laryngeal mask airway. Now, indication, short surgical procedures, we can use it. It's a part of difficult airway. For example, if I'm not able to put the endotracheal tube, I can use this and I can put this laryngeal mask airway. It can be used for cardiopulmonary resuscitation. Contraindications, if you have patient with high risk for aspiration or there is very less compliance of lung, or the pregnancy more than 12 weeks, there is high risk for aspiration, you should try to avoid in such situations. Now, the other instrument, what we have this, what is known as the laryngoscope. So laryngoscope, it's very important. Maybe you have seen this laryngoscope. It's only for airway point of view. It is used to put the endotracheal tube. So we have different types of laryngoscope. We have Macintosh, Miller. What we have in front, it is known as the Macintosh, where there is curved blade. So we have blade, we have handle, and we have this is known as the Macintosh laryngoscope. Now, how we can use it? We have to make sure that we are keeping the patient in sniffing position. Okay, flexion at the neck. What is sniffing position? It has this flexion at the neck and extension at atlantoaxial joint, and we try to align the airway axis. And there could be, this why this position is important. We try to align oral, laryngeal, and pharyngeal axis. So in this, you can get question, what is this position? You just get this on the picture in your exam. What is this? This is the sniffing position. What the exam what we are doing right now, we are trying to align the airway by keeping the flexion of the neck and at extension at atlantoaxial joint in order to align the oral, pharyngeal, and laryngeal axis. Now, preparation before this putting this laryngoscope is that you have to make sure that the suction is available, oxygen supply is there, airway equipments are ready, pre-oxygenation has been done, monitoring and emergency drugs are ready. Now, this is the, maybe you might have seen this. This is the endotracheal tube. This is one of known as the definitive airway. Why it is known as definitive airway? Because it can prevent the patient from aspiration. So we have this balloon here. This is the cuff. This is the connector, and there are other special features about this tube. So if you have been asked in your exam, which of the following instruments is going to prevent the patient from aspiration, or simply which of the following instrument is known as the definitive airway. You have been given option oropharyngeal, nasopharyngeal, laryngeal mask airway, or endotracheal tube. So you have to answer endotracheal tube. It's a definitive airway. Why? It's going to prevent patient from aspiration because it's going directly inside the trachea. Now, Murphy eye, there is one spot or side opening in this endotracheal tube. This is known as the Murphy eye. Now, why there is this alternate tube opening on the side of this? Why there is this alternate tube opening on the side of this Murphy eye? Now, why there is this side opening? This is known as the Murphy eye. So if the main opening gets blocked, patient can have ventilation or rescue breaths from this opening. So this is an alternate passage, and this is known as the Murphy eye. Now, you might have seen this is known as oxygen face mask. You can provide oxygen to the patient, and you can provide up to 60% of oxygen to the patient, depending upon the respiratory rate demand. And this is the variable instrument that we have. So the only problem with this instrument, patient can have claustrophobia. So in a patients where there is problem with claustrophobia, you can use this nasal cannula. It can provide oxygen up to 40%, okay, at a 4 liter, and it's more comfortable to the patient, and patient can be oxygenated with this nasal cannula. The only problem is with this instrument could be if the patient is requiring more than 40% of oxygen, you cannot help with this nasal cannula. So this is all about this topic of airway management. I know most of the things that can be asked in at your level I was discussing during this lecture. What are the indications, contraindication, what is this maneuver, why we do this? It can be asked as a case scenario also, or you can be given simply a picture and you might be asked what is this. So if you have any question regarding this topic, you can ask me. Yes. Any question? Any question regarding this topic? Okay. So I can get this message. So should we start the other lecture? I will just take 5 minutes to start the other lecture. Okay? Is it okay for you? So I will keep, if this link is not working, I will send you another link then. Okay? So I will try to open the other lecture, and we'll see accordingly. If this link is not working, I will send you again. And you can you can send Rima